Hi, I am so delighted to meet you in the program of Ward Rounds. Let us see the case study. 58 years old male patient, a known asthmatic on treatment, presented with breathing difficulty, was found to have following physical findings and laboratory investigation. His higher functions are absolutely normal. He was found to have pallor clinically. There are no remarkable general examination finding, including jaundice and pedal edema, and there is no elevated JVP. Definitely he has tachycardia. His blood pressure is on the higher side. He is quite tachypneic, but despite patient is tachypneic, he is able to sustain the saturation in the room air. His cardiovascular examination is normal, and respiratory system, they are able to hear the extensive wheezing and crepitation. His abdomen is quite unremarkable. And as we suspected, this pallor has been sustained with hemoglobin somewhere around 7.3 and mean corpuscular volume 90 and the platelet 2 lakhs. His urea creatinine normal and his GFR also very normal. His electrolytes revealed definitely there is hyperkalemia. His liver enzymes, I think that they didn't do bilirubin, they checked only SGOT, SGPT. Liver enzymes are quite elevated. So he has been given, he has been placed oxygen and he has been given Lasix and hydrocortisone. So he has received dual antibiotic, linezolid and zone, and he has been prescribed valsartan and azithromycin, and he has been given nebulization. So how will we manage?
Hi sir, as we have discussed in this case study,
Okay.
it is mentioned the patient is having breathing difficulty.
Okay.
Sir, but I just want to know what are the causes of breathing difficulty and how do we classify it, sir?
So any patient who presents with breathing difficulty, so if you look at the list, okay, any standard textbook, so you may have 20 to 25 causes. So it is it is better, it is prudent that to divide the causes into first cardiac causes and pulmonary causes. See, if you segregate dyspnea or if you squeeze dyspnea into cardiac cause, I could say the diuretic will do the needful. So any cardiac cause, probably any patient who presents with tachypnea and there is extensive crepitation, cardiac cause may be whatever it is, maybe MI or valvular heart disease. Once if they present with tachypnea, there must be some crepitations. So definitely this lung crepitations always indicate that there's a flooding of fluid which impair your alveolar exchange, gas exchange. That is the reason patient develops hypoxia.
Okay.
So if you relieve that the fluid accumulation in the lung, definitely you can relieve dyspnea. So if you segregate dyspnea into two parts, always cardiac or pulmonary. So any cardiac patient who presents with pulmonary edema, definitely he deserves diuretic. There is no dispute on that. But in the case if you suspect strongly pulmonary cause, any pulmonary cause, there may be some involvement of airway. So probably airway dilatation may be beneficial. That's the reason we give nebulization. You have phosphodiesterase inhibitor like deriflin and acibrophylline and so on.
Okay, sir.
Okay. Then any lung cause, for example, most of the time it is an infective cause. So probably they may warrant some antibiotic. But the most important would be, I would say, if it is cardiac cause, then I think that diuretic plays a major role. Then if it is an lung cause, then probably the role of diuretics is much limited. In some of the cases, it is not at all warranted. But instead, a patient may require airway dilatation. And if PCO2 accumulation is there, then probably patient may require, depending upon the cause, may require steroid or BiPAP based upon the pathophysiology. But so I would like to always segregate the causes of dyspnea into cardiac cause and pulmonary cause.
Okay.
That's the thing.
Okay, sir. As you have told, there is a cause of pulmonary and cardiac.
True.
But how do we differentiate it, sir? Do we have any distinctive criteria to differentiate between the cardiac and pulmonary causes, sir?
So there are some, I could say, distinguished features that are suggestive of cardiac cause and the pulmonary cause. And many of the time, we have been deceived, because sometimes we may think that it is a pulmonary cause, but when you do echo, there will be severe LV dysfunction. Sometimes, there will be enormous amount of crepitation. We think that it is a definitive cause of cardiac, but if you do echo, everything normal. Even there is something called a cardiac failure with preserved ejection fraction. So if we do BNP, that's also turned out to be normal. Then if you explore the history, then patient may say that patient has a long history of COPD, then they may have chronic asthma. So most of the time, we have been disappointed with the attempts which have made to differentiate cardiac and pulmonary cause. But there are some distinctive features that I am not denying about that. So the most important distinctive features would be any cardiac cause, if only LV failure, okay, they will have flooded creps, okay. That's a in the early stage they will have fine crepitation only in the basal region, and in later stage, if pulmonary edema is quite severe, then crepitations would be prevalent everywhere. Not only it is confined to infrascapular area, intrascapular area, and everywhere. Then what happens, the fine crepitation will become coarse crepitations. So that is a very classical feature. But you are very strong enough to be trained with clinical medicine, but you can hear S3 sound. But I am not very sure when you have coarse crepitation, it is difficult to find out S3 sound. You will have abnormal gallop rhythm you can have. So when I did medicine in MMC, we were able to hear gallop rhythm, S3 sound. That was we were trained by Professor V.K. Rajamani. So just a recall, and I express my gratitude to him. So we have auscultated so many S3 sounds. But when someone presents with severe crepitations, then probably it is very difficult to find out S3 sound as such. But the most important, distinctive, very apparent feature would be you will have extensive crepitation. When someone presents with hypoxia, saturation of 89, 90 with extensive crepitations, then probably you are forced to treat both the causes. Okay. But I could say the classical picture would be there will be extensive crepitation. In some early stage of pulmonary edema, we were able to hear wheezing also. So ultimately the echo would do the needful, but the most important picture would be the crepitation. But the important logic would be the history. That's very, very important. If someone says there is a history of COPD, past history of smoking, then if they have history of asthma, then probably these crepitations alone may not point out cardiac origin. You should keep this existing disease, past history also should be kept in mind. So any COPD patient can present with crepitation which may be suggestive of cardiac origin. So we have witnessed so many patients of COPD and asthma patient, they have some subtle crepitations, okay. For example, when you have acute severe asthma, you may not hear any sounds at all. So otherwise, the thing would be when you have coarse crepitation, sudden onset of dyspnea, coarse crepitations, ECG shows some MI, some form of MI, then if patient has history of valvular heart disease, then probably you can think of these crepitations must originate from cardiac origin. Okay. But if they have a past history of COPD and bronchial asthma, if they have crepitation, still there may be an existing possibility of this bronchial asthma, COPD induced crepitations. But usually they have a crepitation and admixed with wheezing. They will have wheezing. That's one entity. Even bronchial asthma, COPD patient, they can have MI, they can have severe LV dysfunction that may lead to crepitation. So any known case of COPD bronchial asthma, if they present with crepitation, you should keep some form of LV dysfunction in your mind. That is the rule. But any bronchial asthma patient, COPD patient, they have only pure extensive wheezing, okay, without any crepitation, then I think that my suggestion or my provisional diagnosis would be that's acute exacerbation. When you have additional crepitation, when you have predominant wheezing or extensive wheezing in the presence of history of bronchial asthma, COPD, I think that the diagnosis would be straightforward, probably acute exacerbation. But known case of bronchial asthma and COPD patient, extensive wheezing with additional crepitations or only pure crepitations, then think of LV dysfunction also. That's very, very important. So crepitations, the coarse crepitation will be the remarkable feature pointing out the cardiac origin. The predominant wheezing that points towards bronchial asthma and COPD. When you have wheezing and crepitations, probably it should be on either way. I think that, but I could say nothing wrong in treating in both ways. So most of the time, most of the medical officers or most of the young doctors sometimes because of pressure from the attenders, then within short period of time you have to segregate what would be the cause. Then you should convey the diagnosis to the patient attenders. Moreover, patient attenders, they expect always what? Relief. So when you are not able to segregate the causes, when you don't have a setup of echo, or echo may be available, cardiologist may not be available, at that time better to treat in both ways. Okay, you can give both injection furosemide and I could say nebulization, and you can treat them with even or a mild form of steroid also. But generally once echo is done, then probably the cause would be quite obvious. But only one thing is, when you give Lasix, I mean the injection furosemide, if it is a true case of pulmonary edema, most of the time they will pass urine output magnanimously. So if a genuine true case of pulmonary edema, so what happened when you give furosemide? So within half an hour they may pass urine 500 ml, 700 ml. That may point out that we may be dealing with acute pulmonary edema. So that's very, very important.
Okay, so I have one small doubt.
Yeah.
Sir, as you told, for cardiac patient, which is who is coming with pulmonary edema, we used to give furosemide, which is nothing but a Lasix.
Okay.
But what is the mechanism of diuresis in this? So like, how does it act in our body to make that urine output to get out of the body? What is the mechanism?
Most of us, what we think that injection furosemide relieves pulmonary edema by acting at the kidneys, leading to diuresis, resulting in relief of pulmonary edema. It is not so.
That's what we have written pharmacology.
Yeah. So it is not so, because injection furosemide, before it acts at the kidney, the most important is we used to say the hemodynamic effect of injection furosemide. So injection furosemide dilates the veins. That is very, very important. So it dilates the veins across the body and ensure that all the blood that is pooled in the vein, leading to reduction of venous return to the heart. Because when you say pulmonary edema, there is failing heart. So failing heart expects some relief. So the main relief can be given in the form of decreases because decreases venous return. That's called, what you told absolutely, it's a preload. So basically you know very well that heart receives, right atrium receives venous blood everywhere. Then this venous blood enters into right atrium, right ventricle. Then right ventricle pumps into the lungs through the pulmonary artery for oxygenation. So if you reduce the venous return, with the help of some medication, so what happened? The venous return to the heart comes down. So workload of heart comes down. That will give much relief to the ailing heart. That's very, very important. So what it does, injection furosemide dilate the veins. It is one of the powerful venodilator. Then you may wonder that there are few more medication that can dilate your veins as well. To much our surprise, morphine. That is the reason morphine is given in acute pulmonary edema, because morphine not only relieves the anxiety and tachycardia, it is the powerful venodilator among the drugs available in the current market. So morphine dilates enormous amount of veins across the body. So there is immediate stoppage of venous return to the heart. So immediately heart will get much relief. That's very, very important. But the problem is morphine can produce respiratory depression. So no, unless you have better setup, unless you have the setup equipped with ventilator and mechanical ventilation. So the person who should know the because I have experienced the respiratory depression precipitated by morphine. So otherwise, if you have a good setup, then probably morphine can be utilized liberally. So one is injection furosemide and morphine, and another one is NTG, nitroglycerin. So NTG can reduce your vein, can reduce your venous return by dilating your veins. It can reduce, it can dilate your arteries also. So what happened? The NTG can reduce your preload and it can reduce afterload. Even it can dilate coronary arteries. So any patient who presents with MI and pulmonary edema, if you give nitroglycerin, it will dilate your veins. So venous return comes down to the heart. When venous return comes down, you have some relief. Then NTG dilates your arteries. So what happened? Your afterload comes down. So cardiac pumping efficiency improves. Then when you have acute coronary syndrome, it dilates coronary arteries as well. So coronary artery blood flow is established. Your chest pain comes down. So these are the ways. But what you have to remember that injection furosemide, before it acts at thick ascending limb of loop of Henle, before it inhibits Na plus K plus 2Cl minus, it dilates the veins first, by which it relieves pulmonary. That's very, very important.
Okay, sir. In this patient, we have given injection hydrocortisone.
Yeah,
but
sure.
There is another drug called dexamethasone. Which is preferable in this patient, sir? Whether hydrocortisone is best, or we can give dexamethasone also? Yeah,
actually, I could say this patient should not be given hydrocortisone, because the reason would be, I have seen even many consultant and specialists, they used to give hydrocortisone. See, what you have to understand, there are 3 products that are widely available to use or to treat the patients in the market. One is hydrocortisone, another one is dexamethasone and methylprednisolone. Okay, so if you say hydrocortisone has glucocorticoid activity, which is considered as 1. Which is considered as 1. Methylprednisolone 5 times as potent as hydrocortisone when it comes to glucocorticoid activity. And dexamethasone, it is 25 times as potent as hydrocortisone. So any steroid, we should look for 2 things. One is glucocorticoid activity and mineralocorticoid activity. Okay. So the purpose of glucocorticoid activity does help in our body to reduce inflammation and to act against immunity, especially in the case of autoimmune disease. Mineralocorticoid activity, you know very well that mineralocorticoid activity, it will act at the kidneys to absorb the fluid. So whenever you require fluid retention in the presence of hypovolemia or shock, then you require mineralocorticoid activity. When you look at hydrocortisone has equal ratio of glucocorticoid activity, mineralocorticoid activity, 1:1. So it is capable of acting against inflammation because of presence of glucocorticoid activity. It has another equal potency of mineralocorticoid activity. Since it has mineralocorticoid activity, it is good for absorbing the fluid in the presence of hypotension. So generally hydrocortisone can be best given, in 2 conditions. 1, adrenal crisis is a condition where you have lack of both glucocorticoid activity and mineralocorticoid activity. So when you give hydrocortisone, that will address your glucocorticoid activity and mineralocorticoid, because adrenal crisis you will have both the reduction of everything, cortisol and everything. So hydrocortisone is the steroid that should be given during the time of adrenal crisis. When it comes to mineralocorticoid activity, methylprednisolone, yes, as compared to hydrocortisone, it has 5 times of glucocorticoid activity. But mineralocorticoid activity very less. So it cannot be given in adrenal crisis.
Okay, sir.
So when you take dexamethasone, it contains glucocorticoid activity 25 times as compared to hydrocortisone, but mineralocorticoid activity nil. So when it comes to adrenal crisis where you require glucocorticoid and mineralocorticoid activity, then hydrocortisone scores over methylprednisolone and dexamethasone.
Okay.
Likewise, when patient has septic shock, okay, the septic shock is the condition where you have to address the shock, and sepsis, the definition is dysregulated immune response, okay, our host response. So there is some abnormal immunological mechanism which is going on. So when you give hydrocortisone, because of presence of glucocorticoid activity, it addresses the immunological issues present in the sepsis, septic shock. And since it contains good amount of mineralocorticoid activity, because of fluid retention, okay, it is able to elevate your blood pressure. So hydrocortisone is a choice of steroid when it comes to septic shock.
Okay.
So hydrocortisone is very much indicated in adrenal crisis and
septic
shock because of presence of both glucocorticoid and mineralocorticoid activity. But when it comes to methylprednisolone has good amount of glucocorticoid activity, 5 times of glucocorticoid activity as compared to hydrocortisone. So when someone presents with acute exacerbation of bronchial asthma, okay, or acute exacerbation of COPD, in COPD to some extent, we require a drug which can decrease the inflammation, okay, aggressively. So I won't prefer hydrocortisone because dexamethasone, methylprednisolone has good amount of glucocorticoid activity which is badly warranted in acute exacerbation of bronchial asthma or to some extent COPD. So I won't prefer hydrocortisone in those situations. Because someone presents with dyspnea, you may have some confusion whether it is cardiac failure or acute exacerbation of bronchial asthma. If you give hydrocortisone, that will absorb water from the kidney because of mineralocorticoid activity. Cardiac failure may be worsened. Okay, so when you have doubt, so for cardiac failure, give Lasix separately. To address the exacerbation of bronchial asthma, give dexamethasone or methylprednisolone, but don't give hydrocortisone.
Okay, sir.
That's my thing. Okay. So methylprednisolone use during the time of acute exacerbation of bronchial asthma. Then any autoimmune disease where you have to suppress the immunity. So at the time you will go for higher doses. Methylprednisolone 1 gram per day.
Okay.
So dexamethasone, there are some conditions where dexamethasone is really warranted. One is acute exacerbation of bronchial asthma. And cerebral edema secondary to tumorogenic edema. We used to say vasogenic edema because dexamethasone is capable of reducing the vascular permeability in the case of tumor-induced cerebral edema, where it is dexamethasone is avidly used. So these are the differences we could make out.
Okay. So sir, we came to an end. So your teaching was very well, sir. We understood each and every concept very clearly. I hope not only me, the audience also would have understood this concept very clearly. So we'll continue the next question in the next session, sir.
Okay.
Thank you.
Yeah, thank you.